Next speaker is Carlie Stott. So she is a nurse practitioner within the medical oncology program at Ochsner. And I think when the planning committee was sort of looking at the program and what was kind of lacking in what was the established program, we felt that this topic was lacking. So with the emergence of immunotherapy, as we heard from the GI thing, emergence of immunotherapy, well then obviously the management of the side effects and the unique challenges with immunotherapy becomes important. So Carlie is going to tell us all about how we manage toxicities of immunotherapy.
All right. Well, as you heard, my name's Carlie, and I work at the Ochsner MD Anderson Cancer Center. I primarily specialize in melanoma, lung, and head and neck cancer. So my passion has become immunotherapy, and more specifically toxicities, because I'm a nurse at heart. So, and I always will be. So I always strive to try to make things better for my patients while being able to continue to give them these great treatments. All right, so our objectives for this program are to identify the different types of immune checkpoint inhibitors used in the treatment of cancer, recall, prevention, and rechallenge methods associated with immune-related adverse events, recognize some cutaneous and GI toxicities that are pretty common with checkpoint inhibitors, compare and contrast the approaches for managing checkpoint inhibitor-related toxicities, and understand the role of the gut microbiome in immune checkpoint inhibitor treatment. So that was a good intro to my gut microbiome, because it becomes very important when it comes to this topic. So this is just a diagram that shows you the big umbrella of cancer immunotherapy. So cancer immune therapies can be divided into 5 major groups: the regulation of immune checkpoints, oncolytic virus therapies, cancer vaccines, cytokine therapies, and adoptive cell transfer. And then we just have a bucket of others right now. This talk today is going to focus mainly on the immune checkpoint inhibitors and those side effects specifically. Regulation of immune checkpoint inhibitors involves targeting proteins that dampen immune responses, aiming to activate the immune system against these cancer cells. Cancer cells can often evade detection by expressing proteins like PD-L1. Therapies that target these proteins are essentially called the immune checkpoint inhibitors. All right, so this picture kind of depicts immune-related adverse events, and it can show a wide possibility, but by no means does it cover all of them. I found this picture, like just looking at it quickly, it was like, oh, well, it's missing this, this, and this. Although it's not depicted on this visual, a takeaway is to remember that inflammation from these drugs can occur anywhere in the body and can often be unpredictable. So making sure our patients are aware of this fact is very important, and communication is key when it comes to treating these adverse events. All right, so while some adverse events may appear early in the treatment process, others can happen weeks to months after initiating treatment. Side effects are possible even after stopping. Usually on that last slide, when I'm talking to my patients about side effects for their upcoming immunotherapy treatment, that's when they start getting nervous. They're like, I walked in here, I was feeling okay, and then you just went through this entire list of scary side effects. And some of the data I can kind of repeat back to them, though, is like that first bullet, approximately 10% of patients receiving anti-PD-1 antibodies have grade 3 or higher immune-related adverse events. So grade 3 and higher, are pretty severe, and that would require treatment. So you can kind of pretty confidently tell your patients, getting monotherapy, that there's 10% chance of a very serious adverse event. So then they start feeling a little bit more comfortable, but you just tell them it is in your best interest to have all this knowledge. By no means do I expect you to know what to do with it, but I want you to come to me. And if you look at the graphs, you can see variable timelines for these adverse events depending on the immune checkpoint inhibitors that are given. Graph A shows ipilimumab just alone. Graph B is anti-PD-1 or anti-PD-L1 antibodies. And graph C is ipilimumab plus an anti-PD-1 antibody, so combination therapy. So immune-related adverse events in patients receiving combination therapy do have an earlier onset than some of the other immune-related adverse events seen in monotherapy. Grade 3 or higher adverse effects with combination therapy ranges from 30 to 60% and sometimes even higher. The most frequently occurring immune-related adverse event is colitis, followed by dermatological, endocrine, and hepatic events. Just a side note, and this can be seen on the graphs, pneumonitis is exceptionally rare in patients receiving anti-CTLA-4 antibodies alone, as opposed to those receiving anti-PD-1 or PD-L1 antibodies or even combination therapy. And the rate of nephritis with ipilimumab monotherapy is estimated to be around 1 to 2%, but when you go ahead and combine therapy, that can raise up to about 2 to 4%. Risk factors. So I think this is really important. So in the next part of when I'm talking to my patients, and usually this is in the consent process, they want to know, all right, you just told me all these really scary things, like how do I know if, I'm at risk? And there's not a ton of hard data to say, you have X, Y, and Z. There's some instances, and I'll get to those. But I was able to review the literature and find some more possible concrete answers for, our patients that might be at higher risk. So a review of the literature identified certain demographic and social history that may predict an increased risk for these toxicities. And usually it's a combination of multiple risk factors that would predispose a person rather than any single factor alone. And as you can see on here, age under 60 years old, high body mass index, women treated with CTLA-4 agents, men on PD-1 or PD-L1 agents, chronic smokers, those with sarcopenia or low muscle mass tend to have a higher risk of having side effects. Risk factors when it comes to medical history. So one of the things we do know pretty right off the bat is a pre-existing history of autoimmune disease, and even a family history of autoimmune disease seems to increase that risk of toxicities in patients receiving immune checkpoint inhibitors. Inflammatory bowel disease patients do tend to be at higher risk than, say, those with a rheumatoid disease. Allergies to foods, drugs, or even contrast can increase the risk of immune-related adverse events in solid tumors. History of interstitial lung diseases like chronic obstructive pulmonary disease, asthma, history of thoracic radiation can increase the risk for pneumonitis. And likewise, patients with a cardiovascular risk factors such as hypertension, coronary artery disease, heart failure, and myocardial infarction are more prone to these cardiac immune-related adverse events. Chronic kidney disease, stages 4 and 5, pose a significant risk factor for acute kidney injury. And then a sustained decline of an EGFR greater than 20% over 90 days is significantly correlated with higher risk for side effects. When it comes to medication histories, there's some medications that could predispose you to having some immune-related adverse events. Patients with chronic use of proton pump inhibitors and NSAIDs tend to have worsening kidney function when treated with immune checkpoint inhibitors. Diuretics and ACE inhibitors and ARBs are associated with acute kidney injury. Anthracyclines, HER2 inhibitors, VEGF TKIs can increase the risk for cardiac immune-related adverse events. Antibiotics also can alter your chance for risk factors. There was a retrospective study showing that there's a higher risk for immune-related adverse events in lung cancer patients treated with antibiotics, which was also then validated by other studies. And then vitamin D is known to have anti-inflammatory and immune regulatory properties, predominantly by dampening pro-inflammatory agent IL-17. Vitamin D deficiency in cancer patients receiving immune checkpoint inhibitors could be associated with a higher risk for immune-related adverse events and needs further study. All right, there are some tumor-specific markers that we can look for. Patients with melanoma are at higher risk for diarrhea, rash, pruritus, colitis, but they also have the lowest risk for pneumonitis. Breast cancer patients, there's studies showing that there's higher fatal adverse events when treated with PD-1. AML and MDS patients have higher risks for dermatitis and hepatitis. And then some higher disease burden patients and higher tumor mutational burden also lend into having a higher risk for immune-related adverse events. Prevention, that's something else that kind of is near and dear. We want to try to lower that risk for some of these things to happen with our patients. So prevention of adverse events is crucial to ensure patient safety, treatment continuity, and optimal outcomes. It helps maintain patients' quality of life, reduces healthcare utilization, and allows patients to receive the full benefits of their cancer treatment. There's insufficient evidence right now to support the use of prophylactic steroids or anti-inflammatory drugs in the patients without a history of pre-existing immune-related adverse events. There was a meta-analysis suggesting that patients receiving immune checkpoint inhibitors and steroids for any reason may be at higher risk for death or disease progression. All immune checkpoint inhibitors in current practice have fixed doses, and there is currently no scope for modifying those doses as we typically would for chemotherapy. And I have seen some practicing clinicians think of that and thinking that maybe modifying that dose would do that, but that's not how it works. And then you want to also consider an autoimmune history. That's really what's going to tell you right off the bat, like, okay, I know looking at you that we're going to have some issues and we're going to have to try to optimize the treatment of your autoimmune disease to reduce, creating a flare of whatever you have, such as like rheumatoid arthritis, psoriasis, or even inflammatory bowel disease. Rechallenge, that's another big topic because we know our patients sometimes have side effects, but we want to get them back on a treatment that works. So rechallenging patients after an adverse event is another aspect of treatment that is pretty understudied. The risk of recurrence after restarting the same immune checkpoint inhibitor has a 26 to 48% of developing that same immune-related adverse event. Developing a new immune-related adverse event after rechallenge was in the neighborhood of 13 to 30%, but typically these secondary or second side effects that you had are usually not as severe as the initial one. The majority of patients experience a recurrence of that same immune-related adverse event, and regimens with anti-CTLA-4 were associated with higher risk. Endocrinopathies are less likely to reoccur, and I can tell you that just because the majority of those are permanent, so that is why the data is showing that they're least likely to reoccur, because we caused it, there it is, and it's hard to make that happen again when it stays. In one study, it was found that patients who experienced a recurrent of immune-related adverse events had a shorter average time to onset when compared to those in the non-recurrent group. Simply put, these patients experiencing side effects sooner in their treatment course are more likely to experience a recurrence of that same issue. So you can kind of use that as a basis for people that have pretty quick adverse events. You can pretty much assume when you rechallenge it, it's going to continue to be an issue. The most common recurrent immune-related adverse events are colitis, arthalgia, skin reactions, pneumonitis, hepatitis, and the literature reported also neutropenia, even though I don't typically see that. All right, a question we should ask ourselves when it comes to rechallenging with immune checkpoint inhibitors. Should I do it? Rechallenge should be based on the potential risk-reward ratio for each individual situation. First, we need to consider the usefulness of a rechallenge. Restarting therapy could be delayed in a patient that had a complete or excellent partial response. There have been randomized studies showing that patients with immune-related adverse events may have favorable clinical outcomes when discontinuing these treatments. Many patients with ongoing stable or responding disease may not even need a rechallenge. And then we should also consider the existence of other therapeutic alternatives, and that's an important factor. Second, one should consider the clinical and biological state of the patient. Rechallenge should only be considered after the grade of the immune-related adverse event returns to a grade 1 or 0. Third, the potential severity of the immune-related adverse event needs to be evaluated. Because of life-threatening risk, it's advised against rechallenging for any cardiac or neurologic immune-related adverse events, such as myocarditis, Guillain-Barré syndrome, encephalitis, and severe myositis. And fourth, we should consider the ability to estimate the recurrence of that adverse effect. For some, imaging or biological monitoring could be useful in estimating the recurrence or diagnosing it at an early stage. An example of this would be using CT imaging to evaluate the resolution of a pneumonitis. All right, rechallenge strategies. So after a symptomatic recovery, rechallenge can be attempted while on a steroid taper, but the doses must be less than 10 milligrams of prednisone per day, and also after a careful assessment of the available treatment options. So one of the options is de-escalation. You can choose to drop the CTLA-4 agent in patients who had an adverse immune-related adverse event with the combination therapy of CTLA-4 and PD-1. Another strategy, it could be just to resume the same agent, but of course you would want to wait for a complete recovery from that side effect. And thirdly, we can consider combining with biologic agents to help control that adverse event if we want to try to rechallenge them. In instances of using TNF alphas, just a note to use cautiously with myocarditis, and it's not recommended hepatic toxicities. We also have vedolizumab for colitis, we have tocilizumab for inflammatory arthritis, and we have IL-17 inhibitors that can help with psoriasis and psoriatic arthritis. There's no randomized data in the rechallenge setting to inform this decision, and there's even limited retrospective studies that have not done direct comparison between these different approaches, but this is typically what you would see, this is the decision tree that you'll have in your mind when you go to your patient that's had an adverse event and you want to consider rechallenge. All right, so I don't have enough time to talk about the probably hundreds of toxicities that immunotherapy can cause, but I'm going to focus on some toxicities that can be pretty common and sometimes hard to treat. Cutaneous toxicities are one of the more common ones that can happen. It affects between 30 to 50% of patients receiving immune checkpoint inhibitors. Grade 3 or higher cutaneous adverse events are typically observed in 2 to 3% receiving monotherapy, and a little bit higher, 4 to 10% in combination. So those are those really serious cutaneous toxicities. Skin reactions caused by anti-PD-1 or PD-L1 also tend to have a delayed onset in comparison to those receiving those anti-CTLA-4 agents. Rarely do these cutaneous toxicity cause treatment interruptions. Rash, pruritus, and vitiligo are the most widely reported. The occurrence of vitiligo has been linked to better tumor responses and outcomes in patients with advanced stage melanoma. Usually a maculopapular rash affecting less than 30% of the body surface area is pretty typical of what we would see, and it can take on the follicular, pustular, vascular, or even acneiform look. Caution should be used in patients with psoriasis, which I kind of mentioned back in the previous slides. You want to take that into account if you have a patient with a pre-existing history of psoriasis. You may need to get them in with dermatology to optimize their treatment if they really aren't already. And there are some life-threatening cutaneous toxicities such as immunobullous eruptions. Management includes the use of antipyretics such as camphor menthol, topical steroids, antihistamines, and occasionally other antipyretic drugs like gabapentin and pregabalin. Grade 3 is considered macules and papules covering greater than 30% of the body surface area. At this point, it is recommending holding immune checkpoint inhibitors and giving systemic therapy. And if you look up there, that's a picture of a pretty classic rash caused by immunotherapy treatments. It's that macular papular rash. And it can be anywhere on the body. So I tell my patients up front, they're like, where is it going to be? And I'm like, I really don't know. It could be anywhere. So you just tell me when you develop a rash. All right. Biologic agents can be used as an adjunct to treat steroid refractory or recurrent cutaneous toxicities. These may be continued while also trying to attempt that re-challenge. A skin biopsy is important for diagnosing the histopathologic analysis, and that would help with your choice of biologic. There's different ones depending on what we're seeing in that biopsy, such as with persistent eczematous dermatitis, lichenoid rash, or even psoriasiform dermatitis. So there's different ones that can be used off-label in some instances, and then there are some approved. GI toxicity. So this is a big one because when they do happen, your patients are not happy. You're not happy because you're trying your hardest to keep them out of the hospital, just because when you start having, those serious grades of, colitis, you're going to have lots of diarrhea, and it's hard to control that very quickly if it's rapid. So GI toxicities can occur in the esophagus, stomach, small bowel, colon, pancreas, gallbladder, bile ducts, and liver. They typically happen 6 to 8 weeks after starting treatment. Colitis is the most frequently observed immune-related adverse event in patients receiving ipilimumab. So that's 10 to 20% of patients, but I think with combination therapy, I think it's more in the neighborhood of 20 to 30%. Life-threatening complications can result from these GI toxicities, such as ileus, toxic megacolon, and bowel perforation. Grade diarrhea is considered 4 to 6 bowel movements above baseline. And at this point, I typically start collecting stool studies for my patients if they're, messaging, calling, saying, you know what, I've had an uptick, I've had some weird bowel movements today, they're loose, they're watery. Honestly, I tell my patients at 3. Just because by the time we get to 4, I feel like we've already lost some time. So you want to get those stool studies as quickly as you can. And typically I run C. diff, stool culture, oviparasites, pancreatic estolase, calprotectin, and lactoferrin, just to rule out infectious causes. And then also you can detect inflammation with that calprotectin pretty sensitively. Early endoscopy and tissue biopsies are the gold standards for diagnosing immune-related colitis. In management, I tend to avoid anti-motility agents at least until I get that stool sample. So if they have some mild to moderate symptoms, I tell them, give me that stool sample, and I'm okay with a little use of Imodium until we start getting some studies back. But if they are taking some small doses of Imodium, the diarrhea keeps coming, I'm pretty confident of what I'm dealing with. And so it lets me start those steroids a little bit sooner. It just depends on each individual case, but I really would like those stool studies. You want to consider supporting them with IV fluids and advising them of following a BRATS diet just to help, remove any of those irritating factors from your diet that might be worsening that diarrhea. And then for grade 2 above, you want to start those systemic steroids, which is 1 to 2 mg per kg per day of prednisone. And then for any refractory symptoms or failure to respond on steroids, that's when we start thinking about biologic therapies, such as infliximab or vedolizumab. All right, selection of infliximab or vedolizumab is based on the patient and the underlying malignancy risk factors. Both drugs have comparable efficacy in achieving clinical remission in patients. However, there are other factors to consider when deciding on which biologic to use. Vedolizumab is gut selective, which is nice. It's not associated with systemic immunosuppression, and then it has also been linked with less corticosteroid exposure, fewer hospitalizations, and shorter hospital stays. Infliximab, you do have the risk for infections. Also, there is the risk for lymphoma and other non-melanoma skin cancers, but the benefit of that is that there is a quicker clinical response with this drug, 10 versus 17 days. So often the decision on which drug to use is determined primarily on how quickly you need to act. If I have a patient in the hospital or I'm needing to admit them for management, we typically start with infliximab to get hopefully a quicker response. And then in the outpatient setting, we'll transition them to vedolizumab or go straight to vedolizumab should we be able to keep them in the outpatient setting. Gut microbiome. So here starts my slides. So we heard a little bit about that already, but the definition of the gut microbiome, it's defined as a complex community of microorganisms, including bacteria, viruses, fungi, and other microbes that reside in the GI tract. The ecosystem of the microorganisms play a crucial role in various aspects of the host physiology, including digestion, metabolism, immune function, and protection against pathogens. The gut microbiome can actually influence the effectiveness and toxicities of immunotherapy. Lower gut bacterial diversity has been reproducibly observed in patients with a wide range of conditions, including inflammatory bowel disease, type 1 diabetes, celiac disease, and obesity. Differences in the composition of the intestinal microbiome between patients could explain some of the variability in our therapeutic responses, and then also immune-related adverse events such as colitis. The gut microbiome composition was significantly different in patients without immune-related adverse events, or even compared to mild or severe immune-related events. Ways the gut microbiome influences immune checkpoint inhibitor treatments. And I think some of this was already touched on as well, but it can enhance anti-tumor immune responses. By manipulating the gut microbiome, we might improve outcomes of immune checkpoint inhibitor therapies. It can regulate inflammation and autoimmunity. The gut microbiome plays a key role in regulating immune tolerance and inflammation. Imbalances in the gut microbiome have been linked to various autoimmune conditions and inflammatory diseases. By influencing immune regulation, the gut microbiome may impact development of immune-related adverse events associated with checkpoint inhibitors, such as colitis, dermatitis, and thyroiditis. Metabolism of drugs. Certain gut bacteria can metabolize drugs, including immune checkpoint inhibitors. So this could impact the availability and effectiveness of these drugs. And modulating systemic immune function. The gut microbiome affects the immune system outside of the gut by producing substances like short-chain fatty acids and lipopolysaccharides. These substances can change immune responses throughout the body, which could affect how well immune checkpoint inhibitor therapy works and its side effects. Targeting the intestinal microbiome as a therapeutic strategy to augment immune checkpoint inhibitors is still in its infancy. All right, when it comes to antibiotics, literature has found negative impacts and then some positive ones when using antibiotics. Some negative, it can impair efficacy and worsen clinical outcomes when you're using immune checkpoint inhibitors. There is a greater incidence of moderate to severe immune-related adverse events. The duration between antibiotic administration and immunotherapy has an impact, and most of the literature I looked at defined that as antibiotic use within 30 days before starting those therapies significantly worsen overall survival. I found that very interesting when I was looking at the literature. Not that we can really control the 30 days before in some cases, because they come to us and hopefully within a couple weeks we're starting that therapy, but that also, proves that we don't want to overprescribe antibiotics if we don't need them. Different types and dosages of antibiotics may have various impacts. Broad spectrum antibiotics were associated with lower responses and a longer response time versus those of a narrow spectrum. In non-small cell lung cancer patients, beta-lactams, especially penicillins, were significantly associated with impaired therapeutic efficacy of immune-related checkpoint inhibitors. Antibiotic use within 4 weeks of a CAR T cell transplant did increase incidence of neurotoxicity. I found that interesting as well. There is positive relationships seen in liver cancer patients. Antibiotic exposure during the early immunotherapy period, defined as 30 days before and after starting therapy, was found to correlate with an improved benefit. And specifically, quinolones used in HCC patients, they had significantly prolonged PFS. And then there was a study in non-small cell lung cancer patients that found little detrimental effect on overall survival and progression-free survival, indicating that it's probably safe. Probiotic use is pretty controversial, depending on who you talk to and the literature you see out there. There's a lot of literature to kind of sift through, but there are some potential benefits as a way to modulate the gut microbiome in ways that might enhance efficacy. So you could maybe possibly reduce the risk of colitis. Specific probiotics can reduce the risk of colitis in mice. There was a study on that. Reversal of antibiotic-induced effects, so Lactobacillus rhamnosus can improve the efficacy of immune checkpoint inhibitors after antibiotic intake. This happens by restoring the gut microbiome diversity and increasing beneficial bacteria. And in some cases, there were favorable prognosis in trials. There was a meta-analysis indicating a positive association between probiotic use and improved overall survival and progression-free survival in non-small cell lung cancer patients. And combining a live bacterial product with dual checkpoint inhibitor in advanced kidney cancer patients improved response rates and progression-free survival compared to immunotherapy alone. However, there are some safety considerations. There's the theoretical risk that probiotics could interfere with the anti-tumor response and exacerbate immune-related adverse events. So that could happen by compromising efficacy. Improper probiotic use can compromise immunotherapy efficacy and promote tumorigenesis. There are studies indicating that mice given probiotics had larger tumors that failed to respond to immunotherapy. There was mixed clinical results as well. There's a study of melanoma patients getting immune checkpoint inhibitors that found no difference in outcomes between those who did and did not take probiotics, but surprisingly, the non-probiotic users had better outcomes, suggesting that they may not always be beneficial. And a need for caution. Even traditional probiotics should be used cautiously as their impact on immunotherapy outcomes can vary. In some cases, consuming sufficient fiber without probiotics may improve melanoma immunotherapy outcomes. Proton pump inhibitors. PPI treatment should be stopped in patients with cancer that there's no obvious indication for it. There was a retrospective multivariate analysis of 140 patients that showed that baseline PPI use almost halved objective response rates and reduced PFS and OS in patients treated with combination Ipi-Nivo. Where patients do require that gastric protection, consideration should be given to switch to a H2 antagonist as they have not been shown to induce those same issues with PPIs. And the diet. This is a very short slide compared to what we just heard, but a high fiber diet is recommended to support the diversity of the gut microbiome. This is also shown to have better responses in anti-PD-1 immunotherapy in melanoma patients. Patients who consumed a high fiber diet were about 5 times more responsive to immunotherapy than those with a low fiber diet. Refraining from alcohol use has been shown to restore the gut barrier integrity. And common low sugar alternatives can actually disrupt that microbiome balance and diversity. So we should use those cautiously, even though they're in a lot of our foods and recommended by a lot of different diets, like Weight Watchers. I was surprised when I joined that. I was like, all of it is sugar substitutes that are the safe, the foods that you can get your points in. And so I was like, this is pretty eye-opening. And then the gut microbiome, there is a fecal microbiota transplantation, otherwise known FMT. This is the transfer of the gut microbiome from one person to another, either via pills or colonoscopy. There's preclinical research showing that an FMT is valuable treatment to increase the sensitivity of immunotherapy and turn cancer non-responders to responders. In 2 different studies on melanoma patients that were found to be resistant to PD-1 inhibitors, some of the patients who received an FMT had objective responses to reinduction. Immune-related adverse event treatment. So there was also a study showing complete resolution of colitis in 2 patients following an FMT. But there are some risks that could accompany this procedure, such as bacterial infections. There was 1 instance of death from sepsis, so making sure your host or whoever's providing that sample is not harboring pathogenic bacteria is important. And that's it. Here are my references. I had a lot, so they're very small, and I apologize, but hopefully you can see them after.
So very nice, very comprehensive. I have a suggestion. CAGLA, we're supposed to be an advocacy organization. I would like to advocate for immune checkpoint inhibitor tumor registry, because you get such weird effects sometimes in the Guillain-Barré and stuff. And what do you do with that information? It'd be nice if we could collect that, maybe we could find some new things. I don't know if that's.
I agree with you. I think that would be important just because some of these are very rare, like the Guillain-Barré. I have one personal patient that got Guillain-Barré. It's those patients that unfortunately get these serious side effects but have the best benefit from their treatment. But I agree with you. Since these rare occurring ones, we need more information. So probably a registry would be a perfect data area to run, any clinical trial questions that we had.
Something we could maybe try as an organization, put together. I don't know what it would take to do that. But.
Exactly.
No, that's a great point. Any other questions for Carl?
I know that was a lot of information. Hopefully you can take it home.
So, yeah, in the essence of time, and the last that is like seriously, I think we would all have to like do jumping jacks to stay awake at this point. I was going to do a talk on the importance of clinical trials to decrease disparities in outcome, and just like Dr. Stagg mentioned, is that this organization is about finding collaborative efforts that are not necessarily health system specific, but are really focused on improving access to care and clinical trial access, and just improving care regardless of where you live. And so really what I was going to focus on was how each institution may have a clinical trial portfolio that we all don't necessarily know about, but that we would need to be willing and enthusiastic and encouraged to actually share patients, increase accrual, and get people accrued into trials. So on that note, when we talk about PRRT, I had 4 trials. Our strategy for getting clinical trials for rare cancer patients have been what is relevant to this part of the country, because it may be completely different in the Northeast where things are more aplenty. But we have not 1 but 2 alpha particle clinical trials. So for patients with somatostatin receptor avid tumors, we do have PRRT trials, and obviously we have the Lutathera standard of care. We finished accrual. Eve, our director of clinical research, is predominantly responsible for getting us our accrual goals. We had another trial where these patients, a lot of people that don't deal with neuroendocrine patients, these patients are shackled to an infusion center every month to get a painful injection in their backside. And they live greater than 50 miles away from the infusion center. So we had a clinical trial in proactive patients that were going to compare a depot injection where they would learn to give it themselves, and compared it to the standard of care shot that they get in the infusion center for people that had no coverage. For, like I was telling in the keynote speaker, for people that had no coverage for the standard of care monthly injections, that was the only way we were going to get them on the injection. So we had like 2 out of the 3 actually randomized into the standard care arm. We were like, sweet, free drug, yes? And the person that went into the other arm, his wife was a friggin' nurse, and they were like happy. They were like from Mississippi, so happy that they could do it themselves. And then the third was an oral medication in patients with intestinal manifestations of carcinoid syndrome, where we would give the drug. We took them off the injections, gave them the drug, dose escalation, so an earlier stage trial. But that if we can get people off the injections completely, and they live in rural Mississippi or Arkansas or Oklahoma, it would just be huge. And there is no doubt, having participated in those trials, that those things are going to get through the FDA. It's just a matter of time. But the CAGLA and these types of interactions is not keeping everything siloed, but saying, hey, you know what? They're actually doing that kind of stuff. And so I think if we can just ride the momentum to get additional clinical trials here, and then have more collaboration between institutions, I think that we will likely not only increase our accrual numbers, which that's what industry likes, but I just think we'll be able to expose ourselves to more cutting edge therapy. So thank you guys so much for staying until the bitter end.